Yeah, I think we're good. Alrighty, let's get one here. Yep. Says we're good.
Yeah, should be.
Alrighty. Switch over to presentation. Just checking.
Yeah, go right ahead.
Alright. What time is this? 11:56. Yeah. Alrighty. Browser. Okay. Let's turn that up a little bit. There we go.
That work?
Yeah, I think we're good.
Okay.
Righty, so just let Joe know.
Go right ahead.
Alrighty, so hello there. It's I'm Mike back with MEDSec.
And I'm Ian. I was mentioned last time by Kaya, who's my work partner. And I'm with the DFUR team.
Yeah, I see you guys working all the time. Now I'm about to find out what everyone's doing.
Ooh, fun.
Alright, so once again, I'm Michael Verdi. My background is in networking, being a SOC member here at the Leahy Center, hardware repair, penetration testing, software development, systems administration, Active Directory, stuff like that. So I have a wide variety of experience.
And then here's the information for both myself and my partner Kaya. I'm a graduate of Champlain College here. I'm got some proficiencies in VMware, forensic analysis, some bits of system administration that were required to learn, and Python coding. There's some more, but that's some of the main parts.
Yeah, and then here also is the other member of the DFIR team, Kaya. We just wanted to give her an honorable mention. There's her background there and her LinkedIn if you want to follow her. All of our LinkedIns will be on display throughout the presentation. So make sure to give us a connect and a like on all of our blog posts as they come out about our projects.
Okay, so what's been going on with the DFUR team? A lot more research into the topics surrounding our scenario, which is basically large amounts of data in a incident response case. Recently, myself and Kai have been looking into what the standards are for incident response, both NIST and SANS. Click next. On the screen here, you can see the very basic standards of a incident response case, like what you should go through. NIST being the National Institute for Standards and Technology, and SANS being system admin and some other items. Basically, these two are the two forefront players in making these standards for incident response. These two items, they're very similar, almost in structure. They both go through these steps of preparation, doing identification of infected systems and detecting these systems, the steps of containment, eradication, and recovery, and then performing any post-incident activity or reviewing over what they've learned through this incident. As you can see, the NIST has combined the steps of containment, eradication, and recovery into one step, as they believe it's just like one sort of full thing that they're doing.
Now, you said these are the two big ones. Are these just in the U.S. or do these extend throughout the world for DFIR?
As far as I'm aware, these are both used globally. I know that on the NIST site, they have quotes from the government of Japan, Bermuda, and Switzerland talking about how they started to incorporate these standards for incident response in their own plans and everything like that.
Yeah.
As for SANS, I'm pretty sure that it's also a very global standard, since these two are the sort of forefront users.
Yeah. So it is a widespread thing. This isn't just a U.S. based.
Yeah,
standard.
No, it is a widespread thing.
That's good.
So what we've been mostly researching within these standards are what is not crossed out here. In our scenario, we're assuming that this team is an experienced team and they're going through this case. So they've already done the preparation needed to take on this case, such as asking questions to the clients, making sure they have all the proper equipment, and getting whatever they need from the clients, all that sort of thing. And what they're mainly doing is finding out what systems are infected, and then relaying that information to the client, and maybe doing some small containment measures to help with ensuring that the spread doesn't get any farther out, and then handing it off to another team who will then do the eradication, recovery, and everything. Of course, there will be some post-incident response activities, but it's just mainly.
Now, as the incident response, I guess, occurs, is there different priorities into what information you retrieve as an incident response specialist, certain log types or anything like that?
It's kind of varied. There's many things you have to look out for. For example, you have to look to see if there's any evidence of malware on the system, seeing if there's any malicious files, or if the user went to a site that did something on their system, stuff like that. There's also, if the client has it set up, you search through their system logs, any security automations logs, all that sort of stuff, to see if there's any unusual activity or just anything that's anomalous for that client. From there, you can determine you can potentially determine the origin of the malware, or what it's doing, how it's spreading, all that sort of stuff.
Now, and follow up to that, when you're collecting all this information, you're going through different processes. Is there different, overlap between different categories of analysis? If you're doing image or malware or what?
These categories overlap quite significantly, because some of these things you can't do one without the other. Whenever you're taking an image, you are literally collecting an entire, the entirety of a computer system, which means you have the files there, and within these files could be the malicious files. So it's all sort of connected. When you're doing malware analysis, you have to analyze the files that you're doing. You have to know which files you're collecting, all that sort of thing.
Now, what types of documentation are there on this? Do you have to document each step? Is there a chain of custody for each file, or is it just kind of you just go here, analyze, and then you analyze, and you're oh, I found this?
It depends on what you're wanting to do with it.
Yeah.
If the incident is going to be taken to a court case or going to be taking legal action, then absolutely you want to go through chain of custody. It should be recommended that you potentially do chain of custody stuff anyways, just to make sure that nothing's...
Yeah, just to make sure everything's above board.
Yeah, everything's validated, everything like that. But for just identifying and getting rid of it, nothing else is going to happen. It's less so that you're going to do that, but still it's important to do so. That's
good to know. That incident response comes up a lot in medical devices, because that's a requirement that manufacturers have to do. They have to have an IR plan. So there's good context on what that actually means.
Yeah. I can't remember the specifics, like the very specific percentage, but a very small percentage of companies actually like have a in-depth plan, and even then, an even smaller percentage of that actually describe their plans as mature. So it's always something that you have to deal with. And in response, like, you need to go to your client hoping for the best, but expecting the worst. Like, going there is like, you have everything ready, and they're like, we don't even know what we're doing, sort of thing. But
so it's very much behind the ball and where it should be.
Unfortunately, yes. In most cases, a lot of companies are not very prepared.
That's something, you can try to go fix.
Yeah. In our scenario, we are going on the assumption that these people know what to do. So
okay, that's good. All right, so MEDSec. So this week in MEDSec, I tackled a specific branch of medical device. It's called software as a medical device, or in the EU, medical device software. So software as a medical device essentially just is what it sounds like. It's software that is classified as a medical device. This means that it's software that performs the functions of a medical device, but is not a physical hard drive. You can't pick it up, but you can access it through a web portal. It could be an application you install. It could be, a data collection software. It could be a decision-making software. Like if you need you need a therapist, you can open an app. That'll be software because you could be like, oh, I'm this, and this, and then it'll be like, oh, you should do this exercise or call this person or contact these people or you get these drugs. It makes a decision and performs a medical service. And a really good example of this is DIGA in Germany, which is a new initiative they've launched that seeks to create, as they call, a prescription-based medical software service.
Mm-hmm. So, is there a split between general software and the SAMD software?
Yeah, actually, there's one thing that both the EU and the US make very clear is that software as a medical device does not perform general functions. So, if you have in your hospital a software that assigns doctors to different patients, that's not a medical device. Even though it's in a medical setting and it's software, it is not a medical device.
So an example would be like a software that records blood sugar or something like that.
Yeah. If it records the blood sugar and then uses that to help you treat your disease, being like, oh, you need to take your insulin now, or oh, you need to go see a doctor. If it does that, then it classifies as a medical device because it performs a medical service.
Yeah. So how are regulations for these software medical devices approached compared to other types of software?
So
devices?
Yeah, when it comes to software, because they can be installed on different OSs, so like you can install it on a Mac, on a Linux machine, on a Windows machine, they focus a lot more on the security of the information than necessarily its functionality. While it is important that that it makes that it functions as it should, they focus on if it has patient data on it, it has to keep that safe. It has to prevent that from getting leaked to the rest of the machine. You have to make sure that you include in your risk management frameworks, if this software is going to be installed on Windows 10, what vulnerabilities are out there for Windows 10 that could leak into this, or if it's in a web portal that can be accessed through Google, what vulnerabilities are in Google that need to be addressed for your security. So a lot of it is based on ensuring that the information and the integrity of the data is correct than necessarily the physical location of it, because you can't own all the machines that it's going to be installed on.
You can certainly try.
Yeah, you can try, but it's not going to work. And when they have their tests, because a big part is you have to do vulnerability assessments, there's an increased rate of which you have to do them. because software develops faster than hardware. So for a pacemaker, you might have to do it if your firmware gets updated, or you change like a component, but that's a whole new device.
Yeah.
And that's not something that's going to come out every year. But if you update your software, you can do that yearly. You have to do, assessments of that before each release of the software. And you have to make sure that you take into account what's changed, what needs to be fixed, and redo the whole process.
Fun.
Yeah.
Right.
So
what we have here?
So getting back to DIGA, that German program, what is DIGA? DIGA is per MDR, or Medical Device Regulation Standards in the EU, a Class 1 or 2A device, which is a low to medium risk. Okay. So basically that means if the app fails, you're not going to die. Your quality of life will decrease slightly, but you're not, mission critical.
It's not like you're losing
you're not losing a limb or something. You're like, I'm inconvenienced because my app isn't working.
Yeah.
So low risk. It is a key factor is that it's software that's demonstrated immense value to being present, and not just software that exists. It has demonstrated its value through clinical trials, through tests, through case studies, and is something that, if was not on the market, would negatively impact people. The software, because it's by prescription, has to be designed to only be accessed by a patient and not necessarily by a doctor. So, the doctor can access it if they need it, but it can't be like you have to go to a doctor to access it. The patient has to be like, oh, I need to, look at my DIGA, and then you pull out your phone and it's right there. Or you pull out your iPad, or you just pull it up on Google, and then you have it.
Okay.
And it has to perform medical function, which is whether it diagnoses a disease. So you put in your information, and then it's like you have anxiety, or you have PTSD, or something like that.
Yeah.
Or, it monitors it. So it's like, oh, how is your day going? You put in your information, and it goes, oh, your day is good. Or, oh, you should, go take this drug that you've been prescribed. Or, oh, you should go do this. Or, it cures a disease. If it's like, oh, I need therapy, you can get the help from the app as well as a therapist. And these are usually distributed through a QR code that you would then scan, and that would be your prescription ticket. Like if you want the CVS one, give me
DIGA.
give me the whatever it is, your drug.
Yeah.
You can get your DIGA by scanning it. And some of the major security concerns that they have with DIGA is, again, information based. So ensuring that the information that the app collects is only collected because it needs it. You can't just start collecting information.
No.
It has to be specifically related to the app and to the purpose of the app, intended to improve its function.
Yeah, that's a problem with a lot of applications where they just start collecting a bunch of data, and that's concerning.
Yeah, you can't do that. It has to be specifically related to your condition, and it has to be necessary for the DIGA to function as intended. Ensuring that the communication of that information to wherever it's going, if it's going to a doctor or just to another device, that is 100% secure, up to industry standards, so encrypted, session IDs are hidden, it's been tested for vulnerabilities, the information isn't getting communicated to other parts of the application that doesn't need to, so there's a database that's like, oh, these are different conditions, it's not going to get your name and all that stuff. It's going to be like, oh, no, these are segregated, can't cross over. Having access control, so only people meant to see your data can see your data. Again, this goes back to the patient. Only the patient should be able to access it, but a doctor can if necessary. But again, there has to be strict access control to each piece of data to ensure that no one just can go in and go, oh, look, I have Ian's data now. Ooh, it's to be like, oh, there's a password, two-factor authentication. I need to make sure I'm actually Ian, or a facial scan or something like that.
Yeah. Understandable.
Where the app is installed, again, that goes back to accounting for different OSs, making sure you inform users of what version of different OSs it's intended to be installed on. So, if your app is supposed to be installed on, Windows 10, or supposed to be used on Google on Windows 10, it's not going to be used on Windows XP. That's a whole different, problem for, devices or data or security. It's a whole other beast. So you need to make sure that's clear of where it needs to go and what threats exist if it, is on that.
Mage says Windows 11.
I don't think they developed it for Windows 11 yet, but it is still new. So I haven't checked out Windows 11, but it very definitely could be available.
Probably in the process of doing so.
Yeah, probably. They're probably looking into that. There's still not a lot of apps out for Diga. If you look at the Diga directory, I think there's only about 27 right now. So it's a decent number for something that came out like a year or two ago.
Yeah, it is.
But, a lot of them are there on a temporary basis, which means they're under review or they're going through clinical trials at the time. And a lot of them are like therapy apps. Like it's like, PTSD, treatment app or anxiety helping app or,
Understood.
Some sort of psychological, like therapist on your phone, they call it. Making sure that your software is securely, if it has to interact with another system, does that. So again, going back to the information, make sure it's not just leaking information to your Windows machine that's then going to wind up on a, server somewhere where it shouldn't be.
Yeah.
Make sure all that, is packed up tight and locked away somewhere so no one can get to it.
Mm-hmm. Is there any type of oversight required when using or developing a software as a medical device?
Yeah, you have to get it cleared by the German government. You have to, again, prove your clinical trials. And this is kind of for all software, too. You have to prove that it works, prove that it's beneficial, and not just, this is kind of a cool thing to have. Like that it actually has a positive benefit on people's lives and whatever their condition is. Making sure that it's up to date enough, that it's secure, that, if you use it, you're not going to wind up in a data breach every other week. That there's some security, incident response, and accountability available for the manufacturer to ensure that everything that is on that software stays on the software.
Fair enough.
Which then moves over to my final point about DIGA, specifically, which is software vulnerabilities, which is something that they explicitly state you need to keep account of because there's so many different phones out there, because so many people use phones so quickly.
Yeah.
You need to keep an eye on all of that and all of your software vulnerabilities, because if you develop a web portal for your app, but every time someone does or 1 = 1, you're going to start leaking data. It's kind of pointless to have it. It's just kind of an open door. So you got to make sure you do this rigorous testing to make sure your software is reasonably secured. Like you can't stop everything.
No.
But it's secure enough that someone's not going to accidentally go, or 1 = 1, and next thing you know, you've been SQL injected.
Yeah. Aren't those fun?
Yeah.
So now we're going to open this up to any questions that anybody might have to either of us. We'll just wait here for about a minute or a few minutes while we look to see any questions on the chat.
Yeah. So you guys do. So is your incident response specifically like any incident response, like general incident response, or is it a specific branch of incident response?
What we're working on is based on the idea that there's a extremely large attack happening where you have to deal with hundreds of terabytes or like a petabyte worth of data, and you just have to figure out how the heck are you going to go through all this. So
it would be like if you attack the data center, that type of incident response.
Yeah. Well, both think very cool. What are you guys planning next steps? I think Kai mentioned this last time, but we are working on looking at tools next. I know specifically I'm going to be looking a bit into malware tools and malware centralization type tools, since that's a lot of what I worked specifically on. I can't talk. But yeah.
That's good. And for MedSec, I'm moving on to taking all these regulations and all these different rules and procedures and trying to apply them to different medical devices. So different scanners, different actual physical devices, stuff like that.
Ooh. Do you have any idea what physical devices you might get?
Not yet. That's still in the works, but it's looking pretty good.
Yeah.
And for malware tools, do you mean just like malware sandboxes? Or like specific tools that like you put in the malware and it goes, oh, this does this or this does that?
A lot of malware sandboxes are actually what you just described. These are tools that are used to automatically test a malware, basically do dynamic analysis and see what it does, how it affects the system, and just see the changes it makes. It probably also does static analysis, which just goes through the actual like malware file itself and pulls out the components of it to let you know some more of the concepts or ideas of what it's doing. Like, oh, this is a type of function that goes into your registry for your computer and changes some values to where now you're locked out, sort of thing. So yeah, there's also the malware centralization. Like I said, there's actually some services that allow you to collect massive amounts of malware into their system as long as you properly secure it, and it can be accessed by multiple team members across the globe, which is something that is with our scenario.
That would seem pretty useful for some of these malwares that I've seen where they take on different parts. That'd be good. All right. Well, thank you. Make sure to check out the Munich Cyber Security Program on LinkedIn and the Leahy Center. Where we're at currently, to stay up to date with our projects. Again, my LinkedIn is linkedin.com/MichaelJosephVerdi.
LinkedIn.com/Ian Eubanks. And we thank you very much for watching.
Yep. And make sure to tune in next week for CarSec and AMSec, starring our very own Austin Gruposo and William Aller,
who was in the chat. Thank you very much. We hope you have a wonderful